Good evening, all, and welcome Dr. Kalpana Madam, Dr. Riyaz sir, and the senior panelist here. And today is our another episode of Tuesday series, and today we have celebrating the World Asthma Day also. And we have an exciting panel discussion here, led by Dr. Neethu Gupta, and we have panelists Dr.Bindusha Madam, and Dr.Prameela Madam, and Dr.Gopika Madam to join. And we had seniors Purushottam sir and other seniors
Madam,
also
Dr.
joined.
Riyaz sir, and the senior panelist here. And today is our another episode of Tuesday series.
I welcome Riyaz sir to make some opening comments.
So, respected President of IPH Madam, Kalpana Madam, Secretary Dr. Srijit, and the esteemed panelists for the day. So, bronchial asthma, I always say my students also, it is the bread and butter of the pediatrician, and we all should know ABC to XYZ of bronchial asthma. But the frequency of updation of the GINA guideline makes it a very difficult task. So I think Asthma Day is an opportunity for all of us to update and to also listen to the experts in the field. So those who are talking to you today are looking after a huge number of patients, and they have a large number of years of experience. So we can all learn from their wisdom. Over to Dr. Srijit. Thank you. Best wishes.
Okay, thank you, sir. Then we can straight away move on to the academics. So I invite Dr. Neethu Gupta, madam, to start the proceedings. And madam will be the moderator for today's panel discussion, and madam will introduce the panelists also. Over to madam.
Great. Thank you, Srijit. Thank you, IAP, for giving us the opportunity. And let me share the slides and make sure that slides are visible to you.
The slides are visible, madam.
Are you able to see the full slide?
Yes, yes.
Oh, great. Okay. Good evening, everyone. Here today is the World Asthma Day, and we are having next 1 hour discussion on the finer aspects of asthma, which is bread and butter, as Riyaz said correctly. So the topic is navigating childhood asthma. Having experts with us. So let us listen to the experts and see and learn and read. So here, what we understand that evidence alone is not enough, as well as the experience as well. So here what we are trying to do is let us integrate evidence, which is based on GINA guidelines, current guidelines, and the experience, so that we can manage our children with the best possible measures. So I am so happy to introduce my panelist, and I'm so happy to sit in the position of moderator because I don't have to answer, I just have to ask the questions. Okay, so let me introduce my dear panelists. We have Dr. Bindusha, and for today, I'm giving you the color code that is blue Bindusha. Okay, so your slides will be in the blue color. Okay, and so Bindusha, I don't think that I have to introduce you. You are a senior consultant and professor of pediatrics, and probably you are the senior most in the group who is practicing asthma for so many years. And then I have Prameela, pink Prameela. She is wearing the pink dress as well. Okay, and she doesn't need an introduction. She is a very dynamic lady, lot of sports medals and all those things in addition to the asthma knowledge. And then we have green Gopika. Okay, so let us see that how we are going to lead this panel discussion. So what we are going to have is it's like Kaun Banega Crorepati, right? So we are going to have rounds, and you are at my mercy. You need to answer those questions. Okay. So what we are going to do is we are going to have 5 or 6 rounds where we are going to touch upon the different aspects of asthma, like how do we diagnose, what investigations should we do, and how should we manage these children actually, and what are the recent advances. And to our surprise, GINA 25 guidelines came today only, and my panelists have done a good job in reading them in such a short time. And then can we prevent really this asthma, right? So let us look at, this is round 1. So are my panelists ready?
It's sure.
Oh. So the story begins like this. This is a 7-year-old child who comes to your OPD. And the major complaint is he just has recurrent history of cough and some wheezing episodes, which are being treated at the local clinic. Now, parents want to know whether my child is having asthma. Yes or no. You have to kind of tell them the answer that whether my child is having asthma, yes or no. So the question to Green Gopika is, what are the points you will like to ask these parents or the child to ascertain your diagnosis, or that will lead to you to the diagnosis of asthma? So Gopika.
So my time starts now.
Yes, your time starts now.
So first of all, I would like to thank the office bearers of IAP for inviting me as a panelist in this Tuesday academic series. And I'm very happy to have Neethu as my moderator and also my co-panelists, Dr. Bindusha and Dr. Prameela. And as Neethu has introduced every one of us, I will also let, she's such a cool and composed lady. I'm very happy to have her. Okay, so coming to the point, as GINA always says that the 4 cardinal symptoms of asthma is that the child will have cough, wheeze, a feeling of chest tightness, and shortness of breath or dyspnea. But these symptoms can be the manifestations of many other diseases also. So how can we say to a parent that this is asthma and this is not asthma? For that, GINA definitely says that there should be recurrence. There should be variability. What is the variability? The variability of these symptoms, they should be variable in frequency as well as in intensity. For variability in frequency, you should ask a detailed history of the triggering factors, the precipitating factors, and also the relieving factors. So what will be the precipitating factors in a 7-year-old? First of all, when he's having a URI, viral URI, he will be having wheeze and shortness of breath. Or when he is playing after exercise, or when he is exposed to cold, dry air, or when he is having an emotional stress, or when he is having exposed to any indoor allergens like house dust mite or a cold, damp environment. So anything, all small changes which trigger asthma, that you should ask in detail in the environmental history as well as in the present complaints when there's emphasis upon. And meanwhile, in the family, you can also ask about the family history of allergic rhinitis. Does anybody have skin problems, atopic dermatitis? And did the child have an atopic march? Like initially, when he was in the newborn period, did he have atopic eczema? Then followed by the development of this wheeze and cough and breathing difficulty. Did he have any ICU admissions, any life-threatening episodes? Is there any variability, day and night change? The cough more in the early morning hours during sleep. And all these things you have to elicit from the history. And then if these things are variable and these symptoms are variable, along with that, if you have a relieving factors, that is if they go to the local hospital, they take some nebulizations, is it relieved? Or they have some bronchodilator syrup, or if they go to the get admitted and take nebulization, gets it relieved. Any relieving factors, if they go to an environment change, when they go to the native place, when there is a change in environment, is there a relieving factor? If we are able to elicit that from the clinical history itself, you can diagnose asthma. GINA always says asthma is a clinical diagnosis, and if first and foremost, it's a clinical diagnosis. But if you want, you can substantiate it by other evidences.
Perfect. So Gopika has answered my question very well, because that is what we wanted to actually emphasize is episodic, intermittent, aggravators and relievers. That is what we want, and positive family history. So next question to my pink Prameela. What are the clues on the examination you are going to look for in this child? When you examine, you are going to specifically look for those points, either for confirming the diagnosis or maybe for ruling out the diagnosis.
Yeah, good evening, everyone, and thank you, Neethu. I know you are putting a lot of surprises. Okay, some questions will be fresh. Okay, so thing is that after taking a good history, like Gopika said, so most important is a good history. So from the history, you are reached somewhere. Now you have to find out whether that is what you are thinking is right or not. So sometimes the kids will be absolutely fine. They will not have any, they will be fine. And you just put a step and auscultate, there won't be EVs. Chest will be normal. Majority of the time they say cough, normal chest. Urinary will be equal, no. Look at the systems, auscultate.
I think Prameela's connection is not good. Maybe she'll join us back. So what she wanted to say is, on the clinical examination, we actually will not get anything if the child is coming to your OPD most of the times. So we will try to look for the V's, try to look for the prolonged expiration, but usually you don't get anything. Sometimes they may come up with the viral URI-induced exacerbation. So they may have some tachypnea, they may have some V's. In addition, what else we are going to look for in the clinical examination is, you need to look for associated allergic comorbidities, like the children may be sneezing, there may be inferior turbinate hypertrophy on the nasal examination, or there may be atopic dermatitis. So that gives you extra clues to substantiate your diagnosis. Now, what are the other things which will make you suspicious and make you say that no, it doesn't look like asthma? So what are those things is fever. Every time episode is coming with fever, and fever is the first thing, very difficult to say that whether it is asthma or are you dealing with recurrent infections. Then do you have the systemic signs? Systemic signs means any other system is involved, like hepatosplenomegaly or cardiac murmurs or neurological problems.
Yeah.
Yeah. So yeah.
I'm sorry. I don't
are
know,
you back?
Connection.
That's
some connection issues. Am I audible? Am I audible?
Yes, you are audible. Okay, like you can go with the rule out. Rule out aspect.
So you definitely have to roll out, like she said. So you have to look associated things. For example, you have to think of other conditions. So the high fever, wheeze and crackles. Then you know it's more towards infectious. Then you look for other conditions where heart is involved. You have murmur or anything. Look for failure to thrive. For example, severe cough, wheeze, loss of weight, failure to thrive, that will point towards other conditions. For example, your congenital conditions or cystic fibrosis and other reasons. So this is very important that all those masquerades of asthma has also to be ruled out. Okay, clubbing is another clinical sign you have to look for. So it is very clear, very particular, especially this is a 7-year-old boy, so it's much easier. But especially if you're dealing with younger kids, you have to be very clear to rule out asthma. And dysmorphism, sometimes stridor, some associated symptoms, all can have variable this thing. So you have to be very careful in ruling out asthma and ruling in by GINA guidelines, what Gopika has said and what Neethu has said.
Perfect, Pink Prameela. Now my next question is to Bindusha, Blue Bindusha. Okay. So all these things are very easy in an older child, but when it comes to a under 5, we are all confused. Despite being so much experience or so much time working in this field, we still feel confused whether are we dealing with asthma or something else. So what is your opinion on that?
Thank you, Neethu.
If it is a 2-year-old child, yeah.
Yeah, thank you, Neethu. And this is actually, whenever a child, small child, less than 5 years, is coming to us with recurrent wheezing, this is a situation where actually we are not very sure about the diagnosis. This is the age group in which pediatricians tend to overdiagnose and also underdiagnose asthma. So what we can actually look at is to look at the symptom pattern. Okay. So the younger the child, there are more possibilities. And if the patient is actually having wheezing from a younger age group, from the newborn period itself, it is unlikely to be asthma. But if the patient is having symptoms as an older child, it is more likely to be asthma. That everyone knows. And another thing is that these children, small children, babies, they have a smaller airways. So they can wheeze with every respiratory infection. Due to the narrow airways, they will become, whenever there is some infection and the airway become edematous, that itself will lead on to bronchial obstruction and they will come to us with wheeze. So that is the problem there. And actually, the GINA says that we make a diagnosis of asthma by looking at the constellation of findings. So when the patient is having, suppose they used to say that if the patient is depending upon the symptom pattern, sometimes these children may be having very infrequent symptoms. That is only 2 to 3 wheezing episodes per year. And each wheezing episode may last for less than 10 days. And in between the child is asymptomatic. Then this patient is unlikely to have asthma. And most probably this patient is having only viral induced wheezing. That is, there is only one trigger for this wheezing, and this is viral induced wheezing. Whereas when you compare it with the last column, where the patient is having symptoms which are lasting for more than 10 days, patient is having severe symptoms which are severe enough to require hospitalization and all. When there are more frequent episodes, and is more especially if the patient is having in between symptoms. That means in between the infection triggered wheezing, there is a child is still having symptoms. Child may have cough and wheeze, especially during play, after laughing, after running, and also if there is history of family history of allergic diseases or personal history of allergic diseases, this child is more likely to have asthma. Now, we do have another group which is in between these two groups, where the patient may have some symptoms, but we are not very sure whether in between there is symptom or not. There may or may not be family history, or actually we are not very sure whether the patient goes in the first group or second group, or we'll have to give a trial of inhaled corticosteroids to decide whether the patient is really having asthma or not. And actually, we are very happy that today in today's 2025 update of GINA guidelines, they have actually come out with a diagnostic criteria for us to make a diagnosis of asthma in the children younger than 5 years. Actually, the problem with us is that if a child is younger child less than 5 years is coming to us with recurrent wheezing and we are sure that this is asthma, actually, pediatricians are a little bit afraid of making a definite diagnosis of asthma. Now, since the GINA has come out with the diagnostic criteria of asthma, more and more pediatricians will be making a correct, definite diagnosis of asthma. We will just see what is this diagnostic criteria. The first criteria is recurrent acute wheezing episodes, 2 or more episodes of wheezing, or at least 1 episode of wheezing, which is lasting for more than 24 hours, with asthma-like symptoms in between episodes. What is this asthma-like symptom? That means in between the child, in between the episodes, the child is still having cough and wheezing, especially precipitated by running, coughing, crying, and all. So that is the first criteria. And the second is that there is no alternative cause for this recurrent respiratory symptoms other than the viral respiratory infection. So if this is just associated with viral respiratory infection, still it could be asthma, but because we all know that viral respiratory infection is the most common trigger for us. Okay. Along with that, you need one more criteria, that is a timely clinical response of the symptoms to the asthma medications. What does that mean? That means that when you give a short-acting beta agonist for a child with wheezing, there should be response. That response should occur within 20 to 60 minutes. That means 20 minutes to 1 hour. Within 1 hour, the child should have a clinical response. The wheezing should decrease. And even if it is a severe wheezing, or you have to start a short-acting beta agonist and a oral steroids, there also patients should have a relief of symptoms within 3 to 4 hours. And even some children may be prescribed short-acting beta agonists at home. And if there is response to the short-acting beta agonists at home, or if the patient is prescribed inhaled corticosteroids and the parents report that patient is having decreased frequency of symptoms after starting inhaled corticosteroids, we can consider that as the third diagnostic criteria. So if a patient is having all the three diagnostic criteria, we can definitely make a diagnosis of asthma. But if the patient is having only one or two criteria, then we can suspect asthma in those children. And along with these criteria, if there is a family history of asthma, allergy, or a personal history of allergy diseases, that favors the diagnosis of asthma. This is not a must, but if the family history or personal history of allergy disease is there, then our diagnosis of asthma is more confirmed. So that is the latest addition in the GINA guidelines, which is released today.
So now there are only two terms. Either it is a childhood asthma or it is a suspect asthma. It is very, very clear now. Previously, we were writing viral triggered wheeze, episodic wheeze, transient wheeze, all those things. But now they make it more clearer. So that is what it is really a good change in under 5 asthma. So
and
thank you,
asthma
Bindusha.
predictive index is now of no value. If they're saying family history just may strengthen the diagnosis, but it's not required. Previously, they used to say asthma predictive index positive. There are more chance for asthma, developing asthma like that. Now we have
correct. Correct. So thank you so much. And now we the pearls of wisdom we derive from this particular round is younger the child, least possible is the diagnosis. We have to keep our mind open. Stronger family history and atopy, if that is there in the child, more likely is the diagnosis. In the absence of supporting factors, if we don't have anything, repeated documented episodes really help. Because so many times you give nebulization just like that, even without having wheeze, or maybe you are suspecting. But when you have wheeze, please document that, because that helps the other person in making the diagnosis. Okay, 3 episodes have happened or 4 episodes have happened. And always look for the red flag signs. If you get any of these red flag signs, definitely we need to investigate more and then make the diagnosis of asthma carefully. Okay. So let us come to the round 2. So we are very clear about that history and examination findings, right? So now, how do we investigate, right? So Gopika.
Yes.
Once we have taken the history examination, parents will always ask, do we need blood tests? Do we need some X-ray, ECG or something, anything, whatever. So what are the labs actually you will like to order in this child to confirm or substantiate your diagnosis of asthma?
So as I said in the history, asthma is always a clinical diagnosis. But in the definition of asthma, GINA says that you should elicit variable respiratory symptoms, and also you can substantiate it by, or you can confirm it by variable expiratory airflow. For that, we can do some tests. Now, in the 2025 guideline, they have taken this airflow limitation, because sometimes it can be normal also. So they have saying it should be variable expiratory airflow. So the tests available to elicit this variable expiratory airflow are spirometry and a peak expiratory flow meter. So 2 tests are there, PFR, peak expiratory flow rate, and spirometry. But PFR, the GINA specifically says it is not a confirmatory test to diagnose asthma. You can only substantiate asthma. And it is always more helpful in assessing the effect of treatment. That is, once you start treatment, after 2 weeks or after 1 month, you get back the child and ask him to do a PF. If there is a change in the variability to the asthma, to the flow rate, the change in the flow rate variability, that is, initially he has a certain rate. After the treatment starts, his peak expiratory flow rate is more than 12%, more than 13%, then you can specifically say this child is having asthma. This PFR is done using a breathometer. It is very helpful. It is easily available. It can be done even at the PHC. And more specifically, asthma GINA says that if you have what facilities to do a spirometry, then please do spirometry and confirm asthma. How do we do spirometry? Spirometry, actually, we are checking mainly 3 things. We ask the patient to blow through a spirometer and check the forced expiratory volume in the first second and the forced vital capacity of the child. So only 3 values are important in that. So many values will be given in that graph. You see that the graph is perfect. It should have the lower limb is the inspiratory limb, lower part below this thing, and it should have a good start, and it should have a rounded peak and a very good slope. There should be no artifacts. There should be no cough in between. So spirometry is difficult to perform. So because this child is 7-year-old, above 6 years, with a good technician, with a good explanation to the patient, you can make the child do spirometry. And once you do spirometry, look at 3 values. The ratio of forced expiratory volume to the forced vital capacity. Then if that ratio is decreased, okay, you can see if there is obstruction. Then next you look at the forced vital capacity. The forced vital capacity will be normal. Then look at FEV1. FEV1 may mainly used to know the change. After a bronchodilator you give, there should be a change in FEV1. That post-bronchodilator responsiveness is also very important. And how do we do a bronchodilator reversibility test? You ask the child to take a salbutamol nebulization, inhalation, 2 to 4 puffs, and 15 minutes after that, you ask the child to repeat the test. So actually, this is an OP test. You can do it in an OP if you have the facility of spirometry lab and a very good technician. It is high time we all started practicing spirometry in our OPD practice. But in constrained situations in a PHC, please start PFR, peak expiratory flow meter. It is very easy. You can buy it online. It is a breathometer. You can have disposable mouthpieces. Just as in this, the rate is, there is a chart which says the values, the predicted values against the patient's height. So you should have just the facility to measure the patient's height, and there is a standard normogram. So first you measure the baseline patient's peak expiratory flow rate. Then similar to the spirometry, you ask the patient to take inhalation with a salbutamol, 2 to 3 puffs. And 15 to 20 minutes after that, ask him to repeat, ask him to again to blow through the breathometer. So if there is a variability, that is more than 15% variability, then you can say this child is having asthma. Since it is a subjective evidence, that is the mother is seeing the difference, then they will be more compliable. Their complaints will be more, and they will also be very sure that this child is having asthma. And more, we will be finding it more easy to say to them to start on treatment for asthma also. And these were the 2 lab tests we usually do to substantiate, to confirm asthma, and also to monitor the progress in treatment. But now the present GINA says, because of different phenotypes, there is type 2 phenotypic asthma, which is more sensitive to inhalational corticosteroids. For that, they are saying you can do type 2 biological markers, which GINA says as blood eosinophils, if there is high eosinophil count, and also for fractional excretion of nitric oxide, FeNO levels. There are cutoff values. You can do that also. If they don't have facility to do a PFR or spirometry, before diagnosing them as asthma, just do a peripheral smear and a blood count. See if he's having eosinophilia. If you have FeNO inhalation facilities, check for FeNO levels. If it is more than 35 parts per billion, that is also suggestive of asthma. So these are the 3 to 4 lab tests which we will do to confirm asthma.
Thank you, Bindusha. Thank you, Gopika. Now comes Bindusha. Usually parents will ask for that, why don't you do X-ray, and should I do some CT scan and other things? So in your practice, what is the role of imaging? Different types of imaging.
Yeah, the question is actually, should we do all these investigations? As
Correct.
Gopika said, the only investigation that is needed to confirm the diagnosis of asthma is a spirometry, or if the spirometry is not available, PEFR, and you can also maybe look at the eosinophils. Actually, there is no need for us to take an X-ray whenever a child is coming to us with wheezing. sometimes children may see children who are coming to us with a bundle of X-ray, which is taken each and whenever the child is having wheezing. There is no need for taking an X-ray during the recurrent episodes of wheezing. So, what are the indications for us to take an X-ray in a child with wheezing? In the first episode of wheezing, we can very well take an X-ray. Because why? Because we want to rule out any underlying lung conditions like a congenital problem with the lung, congenital anomaly of the lung, or see the cardiac condition. For that, you can take an X-ray when the child is coming to us with the first episode of wheezing. After that, only if your examination shows any focal signs, suppose there is a decrease in the air entry on one side or a bronchial breathing, any focal signs, then we are justified in taking an X-ray. Otherwise, and also if the patient is not responding to our treatment, we have started the patient on the appropriate step in the management, patient is not responding to a treatment, or if there is any complications, then also we can take an X-ray. Otherwise, there is no need for us to take a repeat X-ray for a child with recurrent wheezing. Then should we do an ABG? ABG is also indicated only for an acute exacerbation. That is also for an acute severe or life-threatening exacerbation, where we need to decide whether the patient needs to be ventilated. There also, the decision on ventilation is also based upon your clinical examination findings rather than the blood gas. But at that time, you may take an ABG. Otherwise, there is no routine need for doing ABG or other investigations like CT or bronchoscopy for a real case of asthma. The role of CT and bronchoscopy comes only when the patient is not responding to our management and we are considering an alternative diagnosis, maybe like bronchiectasis and all, then we may be doing the investigations. Otherwise, for a pure and simple case of asthma, there is no need for us to do any other investigations other than what Gopika displayed earlier.
Thank you, Bindusha, for making it very clear that all these things are really not needed. Only thing which has to be done is lung function test. And my next question to Prameela is, lot of people come and ask you about the blood test, and they actually come with the blood test reports also. So when are you going to do allergy testing, and which allergy tests you will prefer for the diagnosis or for confirming the diagnosis of asthma, like eosinophil count, total IgE, specific IgE, or allergic skin testing?
Yeah, that's a very common situation because in OPD, they come to you with a lot of test results, allergy testing and all. So basically, allergy testing, like Bindusha and Gopika rightly said, you need just spirometry to convince that it is asthma. And then, okay, chest X-ray only the first time. And ideally, like that, you just manage the child, and mostly to establish an allergic component, you need to do the allergy testing. For example, you have allergic rhinitis, atopic dermatitis, and asthma for a child. And then you really have to know that whether it is allergic, because allergic rhinitis can be a lot of other conditions also. And another thing is that sometimes for convincing the parents, when you do an allergy testing, especially the skin prick testing, visibly is available, it is in vivo testing, and then visibly it is established that these are the allergens which are triggering the asthma of this thing. So that is for one thing. And about the battery of tests which you had shown, for example, now the type 2 inflammatory marker, eosinophils, see, blood eosinophils, and we are doing, that is fine. But actually G says that there is no evidence that even if these are higher levels rule in, whereas lower levels or normal levels does not rule out also. So total IgE rarely, okay. See, when you have to decide on immunotherapy, which I'll be talking to you later, so then you can do that. But specific IgE, okay, yes, sometimes. But otherwise, it is actually a waste exercise to do all these tests. But skin prick allergy testing can be done if you are an expert in that, if you know the observer variations are there, but still, if you are taught well and you know how to do well and interpret well, this can be done with a proper interpretation, and that too with a standardized extract. I underline and tell you should have a standardized extract to do this testing. It is very important. So if you ask me, somebody is coming to me with recurrent allergic rhinitis and asthma, okay, you can do this. And if you can pick up, suppose it's highly sensitized to house dust mite, maybe if it is refractory, you are planning a allergen routinely people should not order for unless trained can interpret and give an explanation to the parents, because it's very important. Asthma is basically a clinical diagnosis. You go by the guidelines. We have very clear 2025 guidelines. When I went through that, very clearly gives all the tables, columns, and charts how you have to diagnose your asthma, and minimal testing. Spirometry, yes, it's very important. And then pheno, like you said, now it is you have the phenotypic asthma. So type 2, you have to look at the blood eosinophils as well as the pheno. That's it.
That's great. So this round makes it very
Hello?
clear that we just have to go for spirometry, right? That is what main message is,
Yes.
that we need to go for the
Yes.
lung function test wherever it is possible. And if it is not possible, please do PEFR. That is what, as per current GINA guidelines, we want to say, right? So we have made the diagnosis, we
Yes.
have done some labs also. Now the question comes, how do we start managing this child? Okay. So once we have diagnosed, question is, when are you going to start preventers for this child? Because in this field, lot of confusion is there. Many clear-cut guidelines were also not there exactly. Exactly, they don't tell that at what point you should start the preventers. So Gopika.
So when we decide on preventers, actually GINA specifically says that you have to see the frequency of symptoms, not the severity of symptoms. So once asthma is diagnosed by from history and lab diagnosed as spirometry, and in constrained situations PEFR, you have to start on controller therapy. And controller therapy will depend upon the symptom frequency, the 4 symptoms I said. So if the symptoms are infrequent, that is as and when required, you can use, that is the step 1 this thing in the GINA guideline. If symptoms are more frequent, that means more than 2 to 5 days per week, more frequent symptoms, but only day symptoms, you have to ascertain to step 2. But if there are daily symptoms with very infrequent night symptoms, but a low lung function, as demonstrated by a spirometry or PEFR, go for step 3. But if you have frequent day and night symptoms with a low lung function, and also you have frequent exacerbations requiring ICU admission, you start in step 4. So now I will explain what are these infrequent symptoms. So infrequent asthma symptoms means the symptoms of cough, wheeze, breathing difficulty, and chest tightness less than 1 to 2 days per week. For that, the preferred treatment, the preferred controller GINA says is low dose inhaled corticosteroid when required, along with the short-acting beta-2 agonist. GINA specifically says that you have to give low dose inhaled corticosteroid along with the SABA when you are having infrequent asthma symptoms. But if the asthma symptoms are more than 3 to 5 days a week, or 3 to 5 days per week, but the lung function when you do with the spirometry, here comes the importance of spirometry. Lung function is normal, but the child is having symptoms. You can either start on a daily low dose inhaled corticosteroid along with when the symptom exacerbation is there, or when the symptoms come, you can use a short-acting beta-2 agonist. It is as simple as that. But if the child is having daily daytime symptoms, more than 3 to 5 days a week, and night awakening, that is once in a week, very infrequent. And when you do spirometry, you see it's not normal. It is child is having low normal lung function. Then you should start with a daily medium dose of inhaled corticosteroids. Along with that, you can also use a low dose. Now GINA says you can go for a low dose formoterol budesonide combination, that is MART, maintenance and reliever therapy, or you can go for a low dose inhaled corticosteroid with a long acting beta-2 agonist. This is the preferred drug of choices as by GINA. Suppose the child, as I said, is having very frequent symptoms, both during day and night, frequent night awakening, exacerbations, ER visits, ICU admissions, and you see the lung function is very much low, less than 70% of the predicted. You start with a medium dose, either a medium dose ICS LABA or a low dose formoterol budesonide. Along with you have to, if the symptoms are very frequent, you will have to start on oral corticosteroids also, but that is at the last, as a last choice.
So that makes it very clear, because previously these definitions were not very clear, that at what point you will start inhalers, at what point you will label as step 1, step 2, step 3 and 4. But this time it is very, very clear. Now to Bindusha, they have come up with something like track 1 and track 2 management, especially in the adults, that algorithm. So will you explain that what is track 1 and track 2?
Actually, this track 1 and track 2 management is in the for the adolescents and adults. It's not for the children. And here the track 1 management is considered as the preferred track for management, and track 2 is considered as an alternative management. Here actually, what is track 1? Track 1 is actually based on that is a track of management which is mainly based on the ICS formoterol is the major drug that we use in the track 1. Whereas in the track 2, you go for an inhaled corticosteroid, and along with that, you add short-acting beta agonist as an inhaler. And also, when the frequency of symptoms are more, we go for the ICS LABA combination other than the formoterol. So that is basically the track 1 and track 2 management. Can we see the next one? Here, for children above 12 years, that is the adolescents, and also for adults, this is the management algorithm that the GINA has provided. And now looking at the frequency of symptoms, see the last part, see the lowermost part here, whenever the patient is having symptoms which are less than 3 to 5 days a week, with normal lung function, that actually covers the step 1 and 2 for both these for step 1 and 2 in the track 1 we do have only as needed formoterol plus ICS combination. That means even if the patient is having daily symptoms up to 3 to 5 days a week, we need to give ICS formoterol only when the patient is having symptoms, as needed ICS formoterol alone. That is the starting of this track 1 management. And if the patient is having symptoms on most days, almost all days the patient is having symptoms, and also the patient is waking up from the sleep once a week or more, then the patient requires a drug on all days. So you'll have to go for a low dose ICS formoterol combination, which is used as a maintenance and reliever treatment, which will be explained later by Dr. Prameela. And also, when the patient is having daily symptoms with night awakenings on a week or more with low lung functions, you can start with a medium dose ICS formoterol maintenance and reliever therapy. That is the track 1 basically. But whereas when you come to the track 2, in track 2, if the patient is having in the step 1 or 2 symptoms, that means up to 3 to 5 days a week, then what you do is in the step 1, you will give only ICS is taken only when the SABA is taken, as Gopika explained. And if the patient is having the step 2, then low dose ICS is taken as the controller drug, and short-acting beta agonist is the reliever drug. And you may also use ICS plus short-acting beta agonist as the reliever in track 2 management. When the frequency of symptoms becomes more, and it is more than the symptom is there on almost all days a week, then you go for a low dose ICS LABA. Both the LABA that you are using is either salmeterol or something else, not the formoterol, and the reliever is still SABA only. And if the frequency, if the lung functions are less also, then you go for a medium to high dose ICS LABA combination, and SABA is the reliever. So that is the difference between the track 1 and track 2. Now let us see why GINA prefers track 1 over track 2. There is actually scientific basis for this preference of track 1. This is a Cochrane review where they have compared the ICS formoterol combination with both as needed SABA and also daily ICS plus as needed SABA. You can see that when we are using ICS formoterol combination, when compared with this using as needed short-acting beta agonist alone, it actually decreases the emergency visits and hospitalization by 65%. And even when compared with inhaled corticosteroids and with SABA alone, there also it decreased the hospitalization and also emergency visit by 37%. Here, when we are going through the track 1 management, what we are actually doing is that we are titrating the amount of the steroid that the child is getting depending upon the symptom. Because if the patient is having more symptoms, you'll be using more ICS formoterol. So naturally, patient will be getting not only the formoterol, patient also will be getting more inhaled corticosteroids. The patient is having more symptoms. So that will lead on to better control of symptoms. And this ICS formoterol is approved by the regulator in around 50 countries and is also recommended in the asthma guidelines in a lot of countries, around 32 countries. It's even more now. They have recommended this ICS formoterol combination.
That has actually revolutionized the treatment. After coming this formoterol and ICS, this combination has really made it track 1 and track 2, right?
Especially in those children who are having the frequent exacerbation, this is a very good line of management.
Now I'll ask Prameela to explain AIR clearly, because MART has already been covered more or less. So can you explain what is AIR?
Okay. So the GINA 2025 guidelines also very clearly, all the definitions are given very clearly here. So AIR is anti-inflammatory reliever therapy, AIR, anti-inflammatory. So here what they mean by anti-inflammatory reliever therapy is a reliever inhaler which contains both a low-dose ICS as well as a rapidly acting bronchodilator. So that includes your ICS, it can be a budesonide formoterol or a beclomethasone formoterol or your ICS with salbutamol. Okay, so these patients can actually use this AIR. The advantage is they can use it as needed before exercise or some allergen exposure, or this can prevent asthma in such situations. But you should be very careful. Two things you have to note here is anti-inflammatory reliever therapy is ICS plus your budesonide formoterol or beclomethasone formoterol plus your SABA. Non-formoterol LABAs in combination with ICS cannot be AIR. That means suppose you are giving salmeterol, okay, with your ICS, that is not your AIR. And ICS formoterol should not be used as a reliever when you use a maintenance ICS non-formoterol LABA. So sometimes you get confused with all these terms, but it is very clear. So this is your AIR, that is your anti-inflammatory reliever. And MART has already been told, but still I can repeat, it is a maintenance and rescue therapy. Previously it was SMART, that is, that is basically your single inhaler maintenance and rescue therapy. So here the difference is it is a maintenance and rescue therapy is your formoterol, that is your inhaled steroid plus the long-acting LABA, that is your formoterol. So that is your AR as well as the MART. Okay, so here MART also, these combinations you can use, but see here, here also you cannot use a non-formoterol combination. So that is something which you have to be very clear. So I think AIR is a new term. Please read the guidelines 2025. Very clearly it says it is very useful, especially they say in your exacerbations, for especially exercise-induced asthma and all, you can use the AIR also. Hope it is clear.
Yeah. So time is running short, so I'll ask my panelists to little bit speed up the things. What I want is no repetition. Just tell us the algorithms where we are different in each age group. Okay. So Gopika will tell that how will you choose inhalers in general? How do you choose what kind of inhalers you are going to prescribe? And what is your inhaler of choice for 12-year-old child? That has been already told by Bindusha, but still.
So, so when you say about, see, you yourself have been got confused with so many terms, so many inhalers are available. So the optimal inhaler selection, that will depend upon the many things. So GINA says 4 Ps. You see the molecule, that is the preferred one. That is, Bindusha already told, track 1. Then, but you have to think of the phenotype, which phenotype the patient is, whether it is respond to inhaled corticosteroid, whether it's a type 2 phenotype. Then you have to see whether the patient, what is the patient perspective? And also you have many practical issues. That practical issues will include whether it is locally available, whether they can afford that, whether they will master the technique, whether they will be able to, whether they are compliant to that. Everything should be taken into account. What we want is the result. We want the child to have a good life, to be symptom free, and we want the result. Then only they will comply. So once if the child is on step 1 or step 2, but you can start on the preferred molecule. Take the preferred molecule. Which inhaler will the child be? Which inhaler will the child choose? Whether it is a dry powdered one, whether it is MDI or a turbohaler. So if they are very high tech and they know all the nuances, you can go for a turbohaler. It is very effective. Very little amount of this thing drug will reach, the exact amount of drug will be reaching the lungs. But if they have cost constraints, for example, formoterol, a MART therapy, that is the preferred one, formoterol plus this thing, budesonide. You want the patient to have the preferred molecule, but they have cost constraints. You can go for a DPI, dry powder inhaler. The dry powder inhaler formoterol will cost only around 150 rupees. The same if it is, you are giving it as an MDI, meter dose inhaler, you have to prescribe a spacer, and that will cost around 300 rupees. So when you prescribe a drug, first you give importance to the preferred molecule. Then the next important point GINA says is never prescribe a short-acting beta-2 agonist alone. You have to prescribe an inhaled steroid along with that. So either you can give an a short-acting beta-2 agonist along with an budesonide inhaler, or you go for the MART, that is formoterol plus budesonide, a single inhaler, and look at the money constraints and look at the techniques if they will be. If suppose the track one, as Bindusha said, you need to use only as and when required the MART therapy. But suppose the child is not compliant with that, then okay, you can go for a daily low dose ICS and then you give SABA, 2 inhalers. But always give preference, explain to them that this is the preferred molecule, and never fail to prescribe inhaled corticosteroid along with the short-acting beta-2 agonist. Because inhaled corticosteroid early introduction has been found to decrease the exacerbations as well as prevent the airway remodeling. So that should be the take-home message. When you prescribe a drug to the patient, give first importance to the preferred molecule, then see the patient's aspect, discuss with them, take them into confidence, see their money capacity, see how they can master the technique and prescribe the inhaler as well as the molecule.
Yeah, that's very well said, Gopika, because that is very important. How do we choose the drug? Bindusha should guide us that if this child is a 7-year-old child, because there are very minor differences between the age groups. So that is why I'm bringing this question, that if it is a 7-year same child we are preferring, so how do you go for the inhaler of choice?
Actually, how to select the inhaler was very well explained by Gopika, and that actually holds good even for a child less than 7 years. What happens is in children less than 7 years, actually they won't be able to use the DPI well. So we will prefer to go for a inhaler MDI with spacer for these children. And the inhalation technique also will vary depending upon the age that we will come to in the subsequent sets. Here the important thing is that here actually we don't have the formoterol combination in the initial parts at all. Here, the major drug that we use for a child less than 7 years is the inhaled corticosteroid. Now, depending upon the frequency of symptoms, as Gopika very well explained a few minutes back, if the patient is having very infrequent symptoms, you need to give only inhaled corticosteroids whenever SABA is taken only. And if more symptoms, you will continue the patient on a low dose inhaled corticosteroid and give SABA whenever the patient is having symptoms also. There you do have another choice in the step 2, which is the nicotine receptor antagonist, which is a drug which actually I think the parents prefer to use, but this is not a drug which the GINA actually recommends that we use for asthma, because this drug is something which is associated with neuropsychiatric manifestations, and hence there should be a warning that this is associated with some night terrors and all which can occur in children. So the preferred drug or the preferred molecule for a child less than 7 years for asthma control is only inhaled corticosteroid. Then depending upon the frequency of symptoms, the patient is having more symptoms, either you may go for a medium dose inhaled corticosteroids, or you can use a low dose ICS LABA, which we usually use. And then depending upon the frequency of symptoms, you can go for a medium dose ICS LABA and add on drugs as needed. But the major point that I wanted to convey is that the device that we have to use will be mainly an MDI with spacer, and also the major molecule for asthma control in children under 7 years is inhaled corticosteroid.
Yeah, perfectly said, Bindusha. Here, MART doesn't come into picture, whereas in the other group, MART is a major change. And to Prameela, if it is a 2-year-old child, what are the changes you are going to do in your prescription?
Yeah. So a 2-year-old, you have to be very sensitive actually. So because this is a shared decision making, so you have to, because you have to take the parents into conference, you have to discuss with them. And clearly the 2025 guidelines says that, for example, insufficiency for step 1, actually, there is an insufficient data for daily use of a controller. Whereas a child 2, in step 2, step 3, you can start on a daily low dose ICS. So that is recommended now. But mind you, remember what the clinical criteria, which I have already told you, the 3 criteria which you have to satisfy to say that a child of 2 years is actually having asthma. You have to rule out the other conditions. There should be evidence there, and that the 3 points you have to make sure, and then you start. The treatment of choice will be fluticasone propionate, any ICS. That is ICS, you can start. And actually, as a reliever, it is as needed, it is your SABA. That is the preferred treatment.
Yeah. So actually, the younger the child, we will use the budesonide as a preferred salt. But as the child grows up, maybe we can use fluticasone. And that only remains the main cornerstone of the under 5 management of asthma. So round 3 was very exhaustive, but it was very much needed because that tells you exactly how to track the management of these kids. Now, let us see that what is round 4 says.
Yeah. Okay, Neethu,
Once
I don't
the
know,
child,
there's some problem with connection.
yeah,
Yeah, there is
once
some problem
the,
with the connection, but just to add one more, the last line, which I wanted to tell, because, so here, reliever, which should be considered, because most of the cases that I already told, it will be most of the cases, this will be viral induced. So unless you make a diagnosis of asthma, you should be very careful in starting treatment for under 2 years. Okay.
yes, correct.
Go ahead.
So now, once we have put these children on inhaled steroids or whatever maintenance therapy, what are the things you are going to do on follow-up? What are the things you are going to look at, that whether my treatment is working or it is not working? So this question to Gopika is, how will you assess the level of control once you have started this child on inhalers? Gopika.
So once we have started the child on inhalers, we have to call them after 2 weeks to check. We should check the technique, whether they are adhering, compliance, everything. Look for any comorbidities. And after 4 weeks, you can assess the level of asthma control. After 4 weeks, GINA says. So in the symptom control, you have to ask, in the past 4 weeks, has the patient had daytime symptoms more than twice a week? That is, they had to use relievers, SABA relievers more than twice a week. Or if they are using MART, did they require MART for more than twice a week? Any night awakening is said. That is, anytime they had to use MART or a short-acting SABA in the night. Or was there any activity limitation? That is, any exercise limitation or any activity limitation due to asthma. If any of these is yes, if all are no, then that means asthma is well controlled. If 1 or 2 is yes, then means asthma is not partly controlled. And more 3 to 4 means it is uncontrolled. So only these 4 symptoms you can ask, and the interval GINA says it is for the last 4 weeks. And once you do this, you go for spirometry, see how much is the percentage change, the predicted value FEV1. And if it is less than 70% of the predicted value, you can step up. But if it is not less than 70%, you just wait and see, check the adherence, again check whether they are doing it correctly, whether they are complying, whether they are now adhering to the correct way methods, everything you check, and you can wait for 2 more weeks and then see again.
So that is good. That is what we routinely do on follow-up. But Bindusha is going to tell us what else you are going to assess these children on follow-up.
Yeah.
So anything else you want to check for?
Yeah. Yeah, we all assess the symptom control because that is the most important thing. Because the once you start the patient on drug, there should be symptom control. But along with the symptom control, we also have to look for something else also. That is, we have to look for risk factors for the adverse outcomes. What are the most common adverse outcome is the risk exacerbation. If the patient is still getting exacerbation, then our treatment is actually not effective. Okay, so what are the risk factors for getting exacerbation in a particular child? The most common or the most significant risk factor is the uncontrolled asthma symptoms. Whenever the patient is not having symptom control, then that patient is likely to have more exacerbation. Now, that is one thing where we can adjust some treatment and we can get symptom control. Then there are certain other factors which may be associated with exacerbation, even in patients who have lesser or fewer asthma symptoms. What are these factors? The first one is SABA overuse. If the patient is using more and more SABA, that is actually associated with increased risk of exacerbation. Why do these patients use more SABA? That is basically because they actually have uncontrolled symptoms, which actually they may not be perceiving, or they may be using the SABA and the symptoms are masked. So if the patient is using 3 or more canisters per year, that is associated with an increased risk of exacerbations. And if the patient is using 1 canister per month, it is actually associated with increased risk of mortality due to asthma. So SABA use is an important thing. It said that overuse of SABA actually will upregulate the inflammatory markers. So that is something that we need to address. Then the second risk factor is actually inadequate inhaled corticosteroids use. Either we have not prescribed use the inhaled corticosteroids, or the patient is not actually compliant to your inhaled corticosteroid. Whatever be the cause, if the patient is not getting adequate inhaled corticosteroids, that is a risk factor for the patient getting acute exacerbation. Then we also have to look for any medical conditions, especially obesity, chronic rhinosinusitis, GERD, food allergy, and these things are actually associated with increase in the exacerbations. Obesity also is a pro-inflammatory condition which will increase the all the types of inflammation, and also which decreases the ICS response. And obese children are less likely to respond to our inhaled corticosteroids. And whenever there is rhinosinusitis, there is persistent inflammation of the airways, which may also lead on to increased exacerbation, this number of exacerbation. If the patient is continuing to have exposure to the either allergens or irritants like cigarettes, then also and air pollution, this is also associated with increase in the increase in the number of exacerbations. Psychosocial factors are associated with exacerbation. And as Gopika said, type 2 inflammatory markers. Whenever there is an increase in the blood eosinophilia and FeNO, there is increased number of exacerbation. And you can also look at go in detail about the exacerbation history. If the patient is actually, there was severe exacerbation which needed intubation and intensive care, then also severe exacerbation the last year. In the last year itself, the child had severe exacerbation. These are also factors which will tell us that this child is likely to have more. And other than the exacerbation, we can also look for any risk factor for developing persistent airflow limitation, especially low birth weight, preterm babies. They are likely to have persistent airflow limitation, and also you're not using inhaled corticosteroid. That is also another factor which will favor the airflow limitation. And another aspect we need to always assess is to look for any adverse effect due to our drug. We are giving inhaled corticosteroids, and we all know that if the patient is taking inhaled corticosteroids at the prescribed dose, that is in the low or medium dose, and using a spacer, they are less likely to develop adverse effect. But when the inhaled corticosteroid dose is in the high dose range, they can have adverse effect. And another factor that we may not account is that if the patient is not having adequate symptom control, they may be getting oral steroids also in between, which may also add on to these adverse effects. So it is very important that we assess the growth, that we assess the day. At each and every visit, we need to measure the height and look whether our child is having any decrease in the growth velocity. And this decrease in the gross velocity especially occurs in the first year of starting steroids. So that is something that we actually need to look for, especially if the patient is using high dose inhaled corticosteroids. We also need to measure their blood pressure and see whether their child is getting hypertension. Then the common side effect that we usually see are oral candidiasis, because these inhaled corticosteroids may remain in the mouth. The patient can come to us with thrush. And sometimes there may be atrophy of the face. You can see that when the patient is, this usually occurs when the patient is using a mask along with the spacer. Then we will see that all the skin, which is actually covered by the mask, will be atrophied. And on top of that, sometimes there may be fungal infection, which is there on top of that. Those things can actually be addressed by your telling them to clean the face after using the mask at all. Because whenever we keep a mask on top of the spacer, some drug will be deposited on the skin and it may lead on to skin atrophy. That can be avoided by washing the face after after using the MDA. But these are the things that we actually need to address at each and every visit. We just need, we should not limit us to just assessing the symptom control.
Absolutely agreed. Because that is very important, because sometimes parents also say that symptoms are controlled, why don't you come down on ICS? But if they are having those risk factors, that means we have to be careful about titrating them down or whatever. So that is very, very important. So my next question to Prameela is, this child we have started on inhaled steroids as per whatever you recommended, but the child still continues to have symptoms. Now the child has come to you again after 2 months and still he is going on having some cough, some wheezing, some nebulizations and all. So it is kind of like difficult case. So what are you going to do in this child?
Yeah. So when such a situation occurs, rather than thinking it is a difficult to treat asthma, first you have to revise certain things. That is, studies have shown that almost 80% of this situation is because of poor adherence to the prescribed maintenance therapy. So as pediatricians, as specialists, we give good prescription, we train them, we check everything, but the poor adherence to the medication is the most important thing. So poor adherence to medication can be due to a lot of things. Sometimes it can be because difficulty in using inhalers. Sometimes we see, they use the SABA full month and they keep the other medication as a reliever. So all those things happens. And another thing, sometimes it can be unintentional, like some misunderstanding about this. Sometimes they don't like the technique. They are not well told. And intentional poor adherence is very important, which as pediatricians, as specialists, we have to look at. Because perception that treatment is not necessary. Asthma it's okay. This happens. I also had in childhood. So this is one major thing which people say. So you have to think about adherence to this thing. So GINA 25 clearly says the 4 C's. You check what you have prescribed, then you confirm what you are given, then any correction you make, you do that. The 4 C's, you have to look at it. That is one thing. Compliance. Then technique. Technique, it is very important. Go by the standard guidelines, teach them, train them, and make them do. And every visit, ask them to bring back their devices and you recheck. This has actually improved the compliance. So your technique training will improve the compliance. This is another thing. And the third part is you really have to see if there is any coexisting AR. The unified airway disease concept, like unless you treat the allergic rhinitis, as the child grows, your asthma gets controlled. But these allergic rhinitis can still cause the exacerbation. So please treat the AR according to the area classification. And definitely, all these are the main things. The compliance, they can coexist in this thing. And then you have to rethink. Why, if there is any persistence, you have to rethink the diagnosis. Is it an asthma masquerader? In spite of all this, if it is still there. And also persistent exposure to allergens and irritants. So look at what is happening. So you can reduce the house dust mite, colonization, certain things you can do, but still. So these are the major things you have to think when you see, and I said, revise your diagnosis. All the asthma masqueraders, please, one by one, you check, and then you go for your second line investigations. If still, in spite of all this technique, still you feel the child is recurrently having this, reconsider diagnosis and go for your second line investigations.
Perfect. So I think we have nicely managed this case till now, right? We have put up and we have said that, okay, if the child is difficult, then also we should be able to manage. Now comes the next round, which is quite difficult actually. Despite that, still some patients, very less percentage, but there are patients who do not respond to your regime. So how do we manage this difficult patients? Okay, so let us see that. So there is something called severe asthma. We sometimes try to overuse this term, but some cases are really, really a case of severe asthma. So Gopika, question for you is, when will you label this child as severe asthma?
So actually there are two terminologies, difficult to treat asthma and severe asthma. So GINA says that of the, if you take 100 patients, the other slide, Neethu, 100 patients of which only 24% will be in the step 4 to 5. That means in the requiring medium dose and high dose inhaled corticosteroids. Of this, only 17% will come under difficult to treat asthma. And the severe asthma is a subclassification of difficult to treat. That is, of the 17, the red, only 5% will be having severe asthma. So that is a very minor group that we will see using in step 4-5, going on to difficult to treat asthma and severe asthma. So what is the difference between this difficult to treat asthma and severe asthma? Severe asthma is, it is uncontrolled even after optimized treatment. That is all the techniques, adherence, compliance, everything we have checked. We have given the preferred molecule. We are revisiting them often. We are checking lung function, everything. Even after that, it is uncontrolled. That is with the high dose ICS LABA. So in that case, we have to definitely think of adding on biologicals. We have to think of revising our diagnosis, whether it is anything we are missing. We have to check for comorbidities, everything we have to think of, and we need to refer to an expert. Difficult to treat asthma means it is actually due to inadequate treatment. Sometimes the molecule is not okay, or as Prameela rightly said, there are adherence issues, or they may be having some comorbidities which we are not treating subsequently along with this, like allergic rhinitis or other atopic dermatitis or frequent adenoid hypertrophy, something like that, which is not, the patient is not difficult and the disease is not difficult, but something somewhere making it difficult for the physician. That is called difficult to treat asthma. And once we overcome all these difficulties, even then asthma is uncontrolled, it becomes severe asthma. That is only very minority. The 2025 guidelines say it is even less than 5%, 3.9% only go in for severe asthma.
Yeah, absolutely correct. Agreed with you. I think me, Prameela, Bindusha, Gopika, together also, if we think of at our experience, how many of patients these kind of really belong to the category of severe asthma? Maybe we can just count on 1 or 2 like that on fingers. That's all. Rest of the things are like kind of difficult to control. You could check the adherence, compliance, everything becomes all right. So now the next question to Bindu is, what are the new molecules which we can use for these so-called severe asthma, which we hardly have to use, but still we have the possibilities to use them?
Yeah, what are the new molecules that we can use? Here, actually, these molecules are usually recommended only for those difficult to control or severe asthma. The first molecule actually we have discussed about the MART. I'm not going into the MART at all. Now we have the long-acting muscarinic antagonism, which is actually tiotropium is the molecule that we use, where we can add on this drug if the patient is not having a good control on medium to high dose of ICS LABA or medium dose formoterol, ICS formoterol combination, and the patient is not having good control. This is the molecule which may be added on. This is not a drug which can be used as a single drug in the case of asthma, because this is not addressing the inflammation at all. So this is an add-on drug which may be used in step 4 and 5. And now coming to the biologicals, we do have an armamentarium of biologicals. We have the age-old IgE, anti-IgE, omalizumab. We do have the anti-IL-4 antibody, which is the mupilimumab, and benralizumab. Then anti-IL-5 dupilumab is there. then anti-TSLP, that is thymocyte stromal lymphopoietin antibodies for that. So all these drugs, all the monoclonal antibodies, they are needed only for the IgE mediated or the type 2 asthma. So before we go for these monoclonal antibody-based management, we need to go for a phenotypical assessment of those severe asthma, those children who are not getting controlled with your medium dose ICS and requires high dose ICS or even oral steroids for their control. Only for those children, we need to prescribe this drug. And before we go for prescription of this drug, we actually have to do a phenotypical assessment and make sure that this patient is actually having a type 2 asthma. Then only there is a point in adding these drugs.
Yeah, great. But I don't think that any of us have experience to try
No,
or
I have
prescribe
never
these
treated with
medications.
monoclonal antibodies at all.
Correct. Absolutely true with us also.
Same
So,
here.
so Prameela, when are you going to consider anti-allergic therapy or this, which is very much in vogue, very much in fashion nowadays? So you tell.
Okay.
AIT,
So remember,
allergen immunotherapy.
Allergen immunotherapy or AIT. Hope Neethu will remember when we were students at CMC, we were so thrilled to prescribe, so thrilled to make all the combinations. I thought I'll come back and just start. But so many years now, we are not started. So that shows it. So this is just an add-on therapy. If a patient is having severe asthma, which is not responding, but they are sensitized to air allergens. So this should be done by only experts. Okay, you should have good training in prescribing as well as making the extract. And other thing is that it should be a standard reagent. And we were doing the German product we were doing for skin prick testing, but then there are a lot of products available in the market, the reagents, but many of them are not standardized. So you should have a thorough protocol. You should have, if I remember, Neethu, only one person, that is one of our old registrar's son, has been given AIT through CMC we had done. That's only AIT experience for us. And so that we should understand is this is only by experts through standard reagents and through protocols. Okay. So air allergens. Again, next slide, please, Neethu. So another thing is that you should need a monitoring setup. That is one thing. And the most important thing is if you are sensitized to multiple allergens. For example, if I am allergic, so if I do my skin prick test, it is actually everything I am sensitized. That doesn't mean I am allergic. I am sensitized to a lot of allergens. My skin prick test will be positive to a lot of things. But allergy, the clinical manifestation may not be to everything. So AIT is given only for those who have a house dust mite sensitization and a difficult asthma, allergic rhinitis. Okay, so ragweed also during seasons. GINA also clearly mentions only these two indications. And people are doing left-right AIT. I don't know. It is not protocolized. That's what I have to say. So you have skit and slit. Okay, I'm not going into details of this due to need of time. But skit, as it is subcutaneous, and slit is your this thing. But this require longer years, especially subcutaneous. You have to prepare in the correct combination, and you have to give it over 3 to 5 years and follow up. After allergen immunotherapy, is it like you are completely curing? No. Neosensitization to that particular thing can later occur. So that's it about AIT. So allergen immunotherapy, we should all know what it is and we should be very clear. Only experts with adequate experience should do it. And these are the two indications which GINA says it can be used for your house dust mite and ragweed during seasons. And that particular child I was talking about, we had given him for some time and he was okay for some time. This is the only experience we have. Others, me and Neethu had never given allergen immunotherapy. I think same with Bindusha and Gopika also.
Yeah, the field is evolving. Probably we'll get more standardized reagents and protocols and we will start using because this is the only of this child comes and she's pregnant now. Okay. And now it comes, she comes to your clinic. There is a definite positive family history of asthma in the mother. And the parents are going to question you is, can we do something to prevent asthma in this child? Because they are already treating the elder child, this mother, which may help in prevention of asthma in the second child or in the next child.
Yeah, actually, there are no, that is, asthma doesn't follow a Mendelian inheritance, because mother is having, the first child is having, this baby will also have. But now you have to think of genetics as well as epigenetics. So these epigenetics, now some genes like ORMDL3 and DSMD3, they have been linked to chromosome 17. They are said to have asthma susceptibility locus is there. And what is this epigenetics? They are some heritable mechanisms. They are heritable and they are induced by environment. So if you can modulate the environment, the epigenetic changes will not happen and you can prevent asthma to a certain extent. So what are the environment changes that what are the that the mother should be take care of? That is first and foremost is saying smoking. Mother should not be exposed to smoke, that either cigarette smoking as well as diesel exhaust particles, DEP. Then the weight gain, mother's weight, obesity is very important. Then she should also should not undergo extra stress, emotional problems. That all can induce epigenetic changes like DNA methylation in these genes and can induce asthma in the antenatal period. So maternal smoking as well as passive smoke exposure, maternal stress, this diesel exhaust pollutants, the mother's diet, mother's weight gain, mother's stress, everything are the small interventions which we can do to prevent these epigenetic changes and to a certain extent prevent asthma in the next child.
Yeah, because these are the things which are shown to reduce the expression of those genes. You know, genes are there, genes will be there probably, but may not be expressed. So that is how they are trying to prevent asthma in the next sibling. So my next question to Bindusha is, what will you suggest for this mother regarding natal and postnatal interventions? Antenatal we have already discussed. Anything else we can do during delivery or during the infancy period for this child to prevent asthma?
Yeah, as Gopika said, this is actually interplay between the genetics and environment. So we can, in the environment, we can do something. Certain interventions may help in decreasing the expression of these asthma genes. The most important thing, as we say, is the normal delivery. When the baby is passing through the maternal genetic tract, what happens is the baby will be colonized the respiratory tract, and so the GIT will be colonized with those organisms which are there in the maternal genital tract, and this will actually will help in changing the what do you call the
microbiota.
T lymphocytes. Yeah, these microbiota, this normal microbiota will actually help in changing the T lymphocytes through to the Th1 pathway, which will actually favor the which will not favor the asthma phenotype. So that is one thing that we can do. So unless contraindicated, but normal delivery is preferred. And another thing is that we can the exclusive breastfeeding for the first 6 months. As pediatricians, we always say that exclusive breastfeeding should be there for the first 6 months. So that will decrease the number of exposure of allergens in the first 6 months. And another thing, so if possible, avoid antibiotics in the first few years. Then there is the hygiene hypothesis also, which says that if we are bringing up our children and in the younger age group, so if there is an early exposure incidence of allergic diseases later in life. So that is all about the
GINA hypothesis is very important. Bindusha, when we were studying, one line still sticks to my mind. They say you should clean the child, not sterilize the child. Nowadays, parents are trying to sterilize the child. Okay, every time disinfect and every time this thing. Don't sterilize them. Just clean them up. That's all.
Yeah.
So, and now the next question comes to Prameela, and that is the last question of the day. What is your advice regarding lifestyle changes for the children coming to you with asthma? What do you advise them? Because it is a lifestyle disease, right? So what are the kind of things you will like to recommend?
Yeah, so this is the most important part of this discussion altogether, because healthy lifestyle is very important. The first and foremost, let me take diet. So diet, now see, all of us at least listening to us today, we should make a note that you will not refrain these kids from fruits and vegetables. Apple, don't give apple, don't give grapes. No. The diet rich in fruits and vegetables. Allow the children to take all possible fruits and vegetables. But suppose you feel that some people, parents will say, when we give grapes, they cough. But then repeatedly check if it is right. Maybe once he cough, that's all. So diet rich in fruits and vegetables. Allergen avoidance is not needed. That's one. Second is your weight control. So how will you control the weight? So basically stop the snacks and make more of fruits and vegetables and your physical activity. Physical activity has an GINA guidelines say evidence A in actually controlling your asthma symptoms. So all your children, see, I can proudly say me and Neethu, most of our children who are chronic asthmatics, who are on inhalers, they're either into sports, yoga, karate, kalari, swimming, basketball, volleyball, everything. We encourage them to be in sports. So please ask all these kids what they like and physical activity. That's one thing. Then weight control, of course, that's very important. And breathing exercises. Neethu is an expert in that. And I myself, being a chronic asthmatic, the physical activity and breathing exercise has helped me a lot, is helping me a lot. It's a useful supplement to control the symptoms. So breathing exercise regular. You take few minutes telling all this to the parents, convince them, and you try and you can see the difference. Another thing, during exam season, so when they are stressed up, they have emotional stress, panic attacks. This can also trigger this asthma. So there you have to make sure they have some, see, this mobile addiction has to be little, taken away so that they can indulge in reading, exercise, physical activity, diet. So all this has actually an evidence, especially the physical activity. So this will be the healthy lifestyle change I'll be telling the parents and children. And you really can see that these kids do go for kalari, karate, sports, something, dance, all this yoga. Yoga is very good actually. It helps in your breathing as well as activity. So this is your healthy lifestyle. I know Neethu is a guru in that. You want to add, you can add. That's it.
You have said already. Yeah, with this, this was the last question of the day. And with all, whatever discussion we had, our main aim is to let's help our children to breathe freely so that they can grow, they can enjoy, and along with them, we can also enjoy. Thank you so much. And now I'll open it to the discussion for the audience. Yeah. Dr. Srijit?
Questions in
Madam,
the chat box.
Question
It's
chat
9
box, I
o'clock.
think. Yeah, questions you can ask in the chat from the panelists. Where
Either
is
they
Srijit?
understood everything.
Yeah,
They
I think so.
understood.
I think so.
Good
Dr.
evening, sir.
Purushottam,
Good evening, sir.
sir,
Uh,
sir,
good,
please.
good evening.
Good evening, sir.
I enjoyed the session. It was a very nice presentation. Both the moderate this and very happy to see that you included the 2025 guidelines. So please share that also. Okay. A few points.
Yeah.
In the last part, the preventive, there is a discussion on paracetamol role, avoid during pregnancy, avoid during infancy. And we are liberally giving paracetamol, the primary immunization and all. From the early period onwards, reduce paracetamol is one advice usually people stress. The other thing in the early part, asthma mimics the muscular. Obvious things all will be covering, but there are subtle things which may not be obvious. The vocal cord dysfunction, cystic fibrosis, and aspirations from X type of fistula. Things may be subtle things, it may not be obvious. Even the clinical examination, the imaging need to be considered, especially under 5, under 2 asthma. You already stressed the need for excluding all those possibilities. That was nice. And all the other part you have covered, nothing more to add. Excellent learning session.
Thank you, sir. We take those points, what you said. That is absolutely correct. Paracetamol role was there, but I think it is not described in the GINA as
Yeah.
evidence-based. That is what we took the evidence-based only interventions Rest of the thing is controversial.
Yeah.
The other thing is, yes, cystic fibrosis should have been considered, which we, I think, skipped by chance. It was missed, but we agree with that, sir.
You already included that in the discussion initially. I noticed.
Initially.
One thing we all these years we are stressing on the asthma diary. I think that should be the parents should be taught to maintain the asthma diary, and maybe in the coming years more and more of digital and the video and all. Prepare a video, and that can be video can be utilized for the technique of this inhalation and other drug administrations, because that takes away your stress on teaching all the kids in the OP. So in the WhatsApp group also, a small video sharing will be helpful.
Yeah, surely, sir. Actually, the Cipla company already has the videos. They have ready-made videos for each and every equipment. So we may use that, or we may make our own videos also by telling the patients to tell the techniques, and we can use them.
In the recent guidelines, is there any change in the biological age limits and all?
Bindusha?
Actually, sir, I have actually not gone through the whole of the guideline. I got it only today. Sir, go through it and then.
Yeah, we got it today.
But omalizumab is more than 6 years. More than 6 years you can give, provided it really fits into the category.
It was there. It was there previously.
About the vandalisumab and all, is it reduced? It can be used up to lower limit of 6 years. That's what I want to know.
No.
I didn't
not sure.
know.
So that's why.
No, it can't be.
Sure.
Because it's
Can I just say something? I'm Dr. Krishnamurthy.
Yes, sir. Please, sir.
Yeah. See, the biologics have been in the market not for very long, and their use in children has not been used for a long time. The long-term effects of this are poorly understood, and this child's immune system, how much it modifies at a later time, we don't know. So, if asthma can be controlled by other measures, I would rather be not comfortable using the biologics at this stage with the limited evidence. That is number one. Regarding paracetamol, I have looked into the literature, and it clearly says that injudicious use of paracetamol or very frequent use of paracetamol is the only thing that possibly is harmful to health and all, because it suppresses the fever and does not expose the immune system to the antigen and all that, and that's possibly one of the reasons. So, because most often the issue is after vaccination, can you give paracetamol? I have been in situations where, for example, meningococcal vaccination, the recommendation of the Royal Colleges is that you prime with paracetamol. You give paracetamol half an hour before the vaccination is being given, because it produces so high fever, and these children are at a higher risk of developing convulsions. So giving paracetamol after vaccination certainly is not something that we should discourage. If we give it after 6 hours of the vaccination and all that, and give it for 1 day or something like that, I don't think it is going to cause any harm, because that is a thing that is commonly debated, and this is the evidence base at this stage. Thank you.
Yeah, completely agree with you, sir. I think panelists, do you have to say anything?
Yeah, I think 2025 guidelines, actually, we got only short time to go through it, but it clearly says about everything. Certain things are no now. Your inhalation. See, people are using the Maxal for nebulization. That is, again, GINA says no. Then vitamin D, bronchial thermoplasty, a lot of things has been described. It's nice to go through. I just rushed through it because we just had few hours to read. But I think we all need a thorough reading of 2025 guidelines.
It was very nice, Neethu. You moderated it well. You covered all the major parts.
We little bit overshot the time. I'm not happy about that, but yeah, it went very well.
No. Almost we completed all the, all the 7 questions, 7 sets of questions covers the GINA 2025.
Yeah.
Thank you very much.
Yeah, if there is nothing
I
much,
think
maybe we can wind up the meeting, and I'll hand over to Srijit if he is there. Srijit,
Actually,
yeah.
madam, I am there, madam. Actually, I have some connectivity issue. I'm also traveling. Thank you, madam, for conducting this section excellently well, and also thank all the panelists for making a time and doing excellent contribution. And thank all the participants for joining for today's session. Hope you to see in the next episode of Tuesday series. So good night from IEP Toronto. Thank you.
Thank you.
Thank
and
you.
good
Thank
night.
you, and good
Thank
night,
you. Good
everyone.
night.
Good
Thank
night.
you.
Thank you. Thank you, Gopika.
Thank you, sir. Thank you.
Neethu. Thank you.
Thank you,
Bye-bye.
Neethu. It was
Bye-bye.
nice.
Bye, bye,
I
bye.
really enjoyed it.
Yeah,
Yeah,
me
it
too.
was really good.
Me too. Me too.
Okay.
Okay, thank you.
Okay, okay.
Okay, bye.